Okay, electrolytes. So what do you need to know about electrolytes? Well, just like every other concept on the NCLEX, what you need to know is what every other nurse knows, what every other new nurse knows, okay? Somebody graduating nursing school just like you. So the goal is not to know everything about electrolytes, but to know just a little bit more than everybody else. So there's 4 that you want to concentrate on: magnesemias, calcemias, kalemias, and natremias. Now, one of the things that happens in nursing school, as far as electrolytes go, is that your instructors will usually give you a list of signs and symptoms of different electrolyte imbalances. But the boards can't use a list of different electrolyte signs and symptoms. Well, why? Right? Because not every nursing student gets the same list. There's 3 main med-surg books that the NCLEX uses as a reference for establishing the basis of their questions. And, each of these books has different lists. So which one should they test you on? Well, that's not a fair and reliable way to assess your knowledge. So remember, don't freak out too bad. You just have to know what everybody else knows. And I can assure you that after this lecture on electrolytes, that you're going to know way more than all your classmates do, and you're going to be way more confident in answering select all that apply style questions about electrolytes. One of the things that I want you to take into consideration is that boards don't test about exceptions, okay? So you want to look for generalizations when you're studying for the NCLEX, whether you're studying electrolytes or any other concept on your own. You want to look for the generalizations. That's what boards test, okay? So you need to know what every other new graduate nurse knows. So if I asked you to give me, with 90% accuracy, 10 signs and symptoms of hypomagnesemia, hypermagnesemia, hypocalcemia, hypercalcemia, hypokalemia, hyperkalemia, hyponatremia, or hypernatremia, do you think you, or even say 5 or 10 of your classmates, would you be able to do that with 90% accuracy? Well, after we go through some of these, I think that you will be pretty confident that you'll be able to do that. So first we need to start off with a quick concept. I'm going to ask you to categorize things as being hypo or hyper in the body, okay, physiologically. So if I said categorize diarrhea and constipation, would you say diarrhea is hyper or hypo? Well, that's hyper, right? Constipation would be hypo. If I asked you, if I said tetany or muscle weakness, well, tetany is going to be hyper, right? And muscle weakness would be hypo. If I said agitation or lethargy, which one would go where, right? So agitation is going to be hyper and lethargy is going to be hypo. If I asked you about blood pressure, right? That one's pretty obvious. Hypotension is low, hypertension is high. Same thing about whether we talk about respirations, whether we talk about lung sounds. So what I want you to do is think of things as being elevated, hyper, or diminished, hypo. All right. So when you look at magnesemias, you'll see that magnesemias, and this was what goes in the blank, magnesemias do the opposite as the prefix. Okay. And here's a quick tip that you can use on a test whenever you have a tie when it comes to electrolytes. Never pick magnesemia in a tie. Okay. If has something in the signs and symptoms involve skeletal or muscle, in the tie, you're going to want to pick calcium. If the signs and symptoms involve anything else, you're going to want to pick potassium. Okay. The only time you may see something with magnesium is if it's something cardiac related. Sometimes you'll see a patient goes into AFib and then you notice they have a depressed magnesium level. They have hypomagnesemia. But, so that's the only time that anything would be muscle related. It'd be if it was cardiac related. But typically you're going to see potassium affecting the heart more so than magnesium. All right. Now, there is an exception to these rules for magnesemia. Hypo and hypermagnesemia are not correlated to blood pressure. So hyper or hypomagnesemia don't push blood pressure up or down consistently, but it is reactive. up and down. So magnesiemias are not correlated to blood pressure, but they are reactive up and down to magnesiemias. So down below there in a little T section where you have hypomagnesemia and hypermagnesemia in that little chart there, for hypomagnesemia, those are all going to be signs and symptoms that show an elevation in something else, right? Because magnesiemias do the opposite of the prefix. So hypomagnesemia is going to present itself as elevated signs. So if I gave you things on a select all that apply question, you would want to select tetany, agitation, tachycardia, cramps, diarrhea, dysrhythmias, right? All things that are elevated in the body, all signs and symptoms of elevations would go under hypomagnesemia. Because, again, magnesiemias do the opposite as the prefix. So hypermagnesemias are all going to have physiological manifestations of depressed things. Right? So under hypermagnesemia, you would have things like drowsiness, bradycardia, constipation, lethargy, right? So things that are depressions in the body. So on a select all that apply question now, you don't have to memorize lists of stuff, right? Because now you have a strategy for how to answer select all that apply questions about magnesemia. You got a tool. And I gave you a couple that you can put in each of the categories for hypomagnesemia or hypermagnesemia. But if I rattled off 10, 15 more signs and symptoms, you now have a strategy to put those into an appropriate category. So it's not about having a list memorized. It's about having a strategy memorized. Magnesiemias do the opposite as the prefix. It's not correlated to blood pressure, but it will react blood pressure up and down. Okay. So calcemias. Let's talk about calcemias for a moment. Calcemias also do the opposite as the prefix. So magnesiemias and calcemias do the opposite as the prefix. And calcemias also are not correlated to blood pressure, but they are also reactive up and down to blood pressure. So how do you apply those little exceptions, right? The blood pressure issues with magnesemia and calcemia. So if on a question you had a select all that apply question and they were asking you what are some of the signs and symptoms of hypercalcemia, and one of your select all that apply options is hypertension. Well, would you select hypertension as a sign of hypercalcemia, knowing that calcemias do the opposite, but those have the same prefixes, right? Well, you would still select that because it falls into our exception rule. It's not correlated to blood pressure, but it could react it up and down. So if they give you that option, you want to select it. So let's fill out our table there for hypocalcemia and hypercalcemia. We'll start on the right-hand side under hypercalcemia first. Again, I could give you 25 things that you could put on either side of these because now you have a way of categorizing stuff. So if it's hypercalcemia and it's doing the opposite, on the right-hand column, you're going to want to have things that show a depression physiologically, right? So muscle weakness, confusion, lethargy, constipation, decreased deep tendon reflexes, right? Those are all signs of a hypo level in the body, but those would be correlated to hypercalcemia. So then on the opposite side, on hypocalcemia, those are all going to be elevated signs in the body. Things like tetany, seizures. Okay. Now, there's two other ones listed there, the Chvostek sign and Trousseau's sign. Right? For Chvostek, remember cheek. Chvostek, cheek. Chvostek, cheek. A bit of a tongue twister. So for the Chvostek sign, that's when stimulation of the cheek causes some facial twitching. And the Trousseau's sign is a little more subtle, and that's when you'll see that when you're inflating a blood pressure cuff, you'll see the the client, their fingers will start to twitch a little bit as you inflate the blood pressure cuff. So Trousseau sign is a blood pressure cuff, and Chvostek's cheek. All right. Now, before we go on to talk about kalemias, I want to drop in another test-taking strategy or tool that you can use. So sometimes people will see questions about electrolytes, but they're not assessing it like, what are the signs and symptoms? They might ask you a more application-style question where they're asking you to apply the knowledge that you have. So if I said you have a patient with hypercalcemia, and you have a patient with hypocalcemia, and I said, for which patient should you have padded bed rails? Or for which patient should you have an ambu bag ready? Well, the patient who's on seizure precautions would be the one with hypocalcemia, right? Or the one who needs to have an ambu bag ready is going to be the one who's going to go into respiratory depression, right? Which would be the hypercalcemia. So you can see that they could throw you lots of different styles of questions at you. How have you applied this knowledge that you have now? So who would be on fall precautions, right? The person who's has elevated signs and symptoms or depressed signs and symptoms? Well, it would be the person with depressed signs and symptoms. And for calcemias and magnesemias, that's going to be the person who has the opposite prefix, right? So the hypercalcemias and the hypermagnesemias are the people that are going to be on fall precautions and need the ambu bags, right? The hypos for magnesemias and calcemias are going to be the ones who you're going to want to have seizure precautions ready, right? So you can see how they can ask you tertiary questions to this core knowledge that you have. And so you don't be afraid on a test when something doesn't come right out as you've studied it, right? You can use critical thinking to take the knowledge that you have and start to apply it. So let's move on to kalemias, right? Potassium. Kalemias do the same as the prefix, but there's two exceptions: heart rate and urinary output. They're inversely related, all right? So kalemias do the same as the prefix except heart rate and urinary output. So again, on that select all that apply question, you're going to get rid of the exceptions first. So if it's asking you about hypokalemia, hypo typically is going to do the same as the prefix, except for this one, we want to have two exceptions. Hypokalemia is going to have elevated heart rate and increased urinary output, right? So tachycardia and increased urinary output go under hypokalemia. Everything else is going to be the same as the prefix. So if I said stuff like hypotension, flat T waves, lethargy, coma, drowsiness, right, bradycardia, those are all things that are going to go under hypokalemia because those are all have the same prefix essentially, right, except for tachycardia, which is increased heart rate, and increased urinary output. So bump over to the other side of that table to hyperkalemia, right? Everything's going to have the same prefix because kalemias do the same as the prefix, except for you're going to have bradycardia and decreased urinary output when you have hyperkalemia. So the rest of the things in that list, other than those two exceptions, which you can put by the asterisks there, are going to be things like hypertension, agitation, tetany, seizures, right? So those are all things, tall T waves. Those are things that you're going to see under hyperkalemia, and those would be great options to select on a select all that apply question. So these hopefully give you some tools for select all that apply questions so you don't have to memorize, number one. And number two, like, you should be looking forward to answering a select all that apply question now about potassium, right? So if somebody says we've elevated potassium, we got a select all that apply question, your eyes should be lighting up when it's exam time. And guess what all your classmates are doing? They are freaking out, all right? So you're going to totally dominate these on the NCLEX. I'm totally confident in that. Last one here, natremias. So natremias, you don't really pay attention to the prefix. All right. Natremias are more, the signs and symptoms are more associated with those of fluid overload and of dehydration. All right. So if you look at the bolded letters in those sentences, hyponatremia, you want to think fluid overload. Hypo, overload. And for hypernatremia, you want to think dehydration. Okay. So hypernatremia, dehydration. The E's go together. Hypo, overload. Hypo, overload. The O's go together. All right. So now down there on the T section of the diagram where it says hyponatremia, right above that, write fluid overload. And on hypernatremia, write dehydration. All right. So when you get to the NCLEX and you get a question about this, you are going to be provided with a dry erase board. So write this on there, right? Put the O's on there and put the E's on there and match up which goes with which, and then switch it. So don't be thinking about hypernatremia. Okay, see how the E's are associated with dehydration, hypernatremia, and start thinking of signs and symptoms of dehydration now, right? Or of fluid overload. So for hyponatremia or fluid overload, what are some signs and symptoms of fluid overload? Well, if I said lung crackles, that would go under fluid overload. Jugular vein distension, a patient who's on fluid restrictions. This is a person who's going to have 3+ edema, right? Those are all signs of fluid overload. And if I asked you some signs of dehydration, right, what are you going to say? Well, you say the person's going to be thirsty. They might be hypotensive. They're going to be on a diet that's encouraging fluids. You might be giving them a fluid bolus through the IV. They might have increased body temperature because it's difficult to regulate your body heat if you're dehydrated. Right? So, 5 minutes ago, if I asked you for 10 signs and symptoms of hyponatremia and hypernatremia, it'd be pretty intimidating. But if I asked you now, what are 10 signs and symptoms of fluid overload and dehydration, and you gave you a select all that apply question, I'm pretty confident that you would totally crush it. So, those are the 4 strategies that you can use for electrolyte questions, right? So magnesiemias and calcemias do the opposite as the prefix, except for they're not correlated to blood pressure, but they will cause blood pressure to go up and down, but it's irregular and based on other physiological things going on in the body. For kalemias, they do the same as the prefix, except for heart rate and urinary output. And then for natremias, remember, hyponatremia, think fluid overload. Dehydration, you want to think hypernatremia, right? Match up the O's and match up the E's. There you go. You're totally going to dominate questions on the NCLEX. Select all that apply questions and all the other question formats about electrolytes. So while we're talking about electrolytes, I want to throw in a couple other things on some indications of disorders. The earliest signs and symptoms of an electrolyte imbalance are numbness and tingling. All right? But it might not say numbness and tingling on the exam. All right? Remember, the NCLEX is a vocabulary exam as much as anything else. So numbness and tingling, the medical term for that is paresthesia. Okay, numbness and tingling is paresthesia. So that's the earliest signs of an electrolyte imbalance, are numbness and tingling. Now, the universal sign or symptom of an electrolyte imbalance is muscle weakness. Right? So that's universal across all of them, muscle weakness. But the earliest sign is going to be that paresthesia. Now, for treatments, I got 5 rules here. Number 1, never push potassium IV. All right, I'm sure you heard that a million times in school. Don't push potassium IV. All right. So number 2, you don't want more than 40 micrograms, not more than 40 mics of potassium per liter of IV fluid. So those are some rules you want to think about when administering potassium if it's low. If somebody has a low potassium. Now, here's just a quick general rule that you can think about when you're seeing prescriptions for potassium replacement. 10 micrograms or 10 mics of potassium should increase your patient's potassium level by 0.1. So if you have a patient comes in with a potassium of 3.0 and the physicians want to get them up to a 3.5, how many micrograms would you expect them to prescribe? So this patient needs to come up by 0.5. So you need 10 micrograms per 0.1, so you're going to see most likely a prescription for 50 micrograms of potassium. Now, they're not going to give it to them all at once. They might give it to some of them over by PO, and some of it might be IV. They're going to give it a couple of different ways. You don't want to bring it up too fast, but that's just a general rule that you can think of. So if a patient has a potassium level of 4.8 and they're being prescribed potassium 50 mics PO, then that may be an order that you're going to want to question. Okay, so here's some electrolyte treatments. Number 3, 4, and 5 are for when your potassium level is high. Okay, now remember, we're nurses. We're not diagnosing and we're not prescribing. So these are things that we're just going to anticipate doing and just give us an understanding of what's happening with our patients and what most likely we're going to be doing as interventions for high potassium levels. So number 3 is we're going to want to give calcium gluconate for a stat reduction in potassium. All right, and you're going to see that done most likely if somebody has a lethal arrhythmia. So if they're asymptomatic in terms of their cardiac function, then you may not see calcium gluconate. They may take it out a little bit slower, but calcium gluconate will get rid of potassium level in your blood pretty quickly, right? Now, number 4 is you may see them give D5W with regular insulin. And that's going to essentially hide the potassium under the bed. So how does that work? Let's think about it. Well, what does insulin do in the body? Insulin is a storage hormone. That's pretty much all it does, right? So insulin is the key that opens up the cells to store stuff. Typically, you see that with sugar, right? So with blood sugar, it's going to be lowered with regular insulin because it opens up the cells, the blood sugar rushes in. That's why they give the D5W with the regular insulin, because one of the other things that your cells will store when they're opened up with the insulin is potassium, right? The sugar goes in and the potassium goes in. The cells close up and hang on to that potassium and that glucose for a little while. And in this case, it's dextrose, but so it's not in the bloodstream anymore. So it's not going to be affecting the heart as much, but it's still in your body. So it's going to come back out eventually. It's just like sweeping your clothes underneath the bed, right? The room looks clean, but the crap's still in there. You got to deal with it at some point, but it's going to start leaching out slower. You're going to want to monitor that potassium level over time. Now, number 5 under electrolyte treatments, for a long-term excretion, you want to give K-Excellate for a long-term excretion of potassium. And that's going to trade sodium for potassium. So as the potassium level goes down, the sodium level is going to go up, right? So you're going to have hypernatremia. So we're going to need to treat that hypernatremia. Well, how do you treat hypernatremia? Well, just like you treat dehydration. So we're going to give them fluids, right? Not a big deal. Now, one thing you want to think about with K-Excellate, when I say K-Excellate in my head, I don't say K-Excellate. I say K exits late. Because as K-Excellate is excreting potassium from your body, it's doing it slowly. It's doing it late, right? It's not doing it early and fast. It's doing it late. So K exits late. So in conclusion of all these strategies for electrolytes, remember, magnesiemias and calcemias do the opposite as the prefix, except it's not correlated to blood pressure, but it is reactive up and down. Kalemias do the same as the prefix, except for heart rate and urinary output. For natremias, for hyponatremia, think overload. For hypernatremia, think dehydration. Now, I asked you before, how many of you or your classmates could, with 90% accuracy, give me 10 signs and symptoms of magnesiemias, calcemias, kalemias, and natremias? Well, I'm fairly confident that you have way more confidence in yourself to be able to answer those kind of questions on an exam. And that is what is going to help you totally dominate the NCLEX, because trust me, you now know far more than not just most new grads know about how electrolytes affect the body physiologically and how they'll manifest, but more than most nurses. So you, my friend, are going to do well on the NCLEX.